Stroke is defined as a sudden onset of focal neurological deficit due to a vascular cause in the brain, lasting more than 24 hours. It is classified into three major types: ischemic stroke, hemorrhagic stroke, and transient ischemic attack, TIA. Ischemic stroke accounts for approximately 85% of cases and results from arterial blockage causing infarction of brain tissue. Hemorrhagic stroke comprises around 15% and is caused by the rupture of a cerebral blood vessel, leading to bleeding into the brain parenchyma or subarachnoid space. TIA is a brief episode of neurological dysfunction caused by focal cerebral ischemia without evidence of infarction, typically resolving within minutes to hours. In ischemic stroke, the most common mechanisms include arterial thrombosis due to atherosclerotic plaque rupture, embolism from cardiac sources such as atrial fibrillation, and systemic hypoperfusion during shock or cardiac arrest. These mechanisms result in a sudden reduction of cerebral blood flow, depriving neurons of oxygen and glucose, which causes irreversible cell death over time. Conversely, hemorrhagic stroke typically occurs due to rupture of small penetrating arteries weakened by chronic hypertension, aneurysm rupture leading to subarachnoid hemorrhage, or arteriovenous malformations. The sudden accumulation of blood increases intracranial pressure, compressing brain tissue, further impairing perfusion, and triggering neurological deficits. TIA occurs when cerebral blood flow is transiently interrupted, usually by a small embolus that quickly dissolves or moves on, resulting in reversible symptoms without infarction but signifying high risk for future stroke. The clinical presentation of stroke varies depending on the type and affected brain region. In ischemic stroke, patients typically present with sudden onset unilateral weakness affecting the face, arm, or leg, accompanied by aphasia if the dominant hemisphere is involved, visual field defects, or sensory loss. In contrast, hemorrhagic stroke often presents more dramatically, with a sudden severe headache described as the worst headache of life, accompanied by nausea, vomiting, altered consciousness, and rapid neurological deterioration. In TIA, the patient experiences transient neurological deficits such as weakness, speech disturbance, or visual symptoms that completely resolve within 24 hours, without evidence of infarction on imaging. The initial diagnostic test for suspected stroke is a non-contrast CT brain scan, which rapidly distinguishes between ischemic and hemorrhagic types. Hemorrhagic stroke appears as a hyperdense area indicating bleeding, while ischemic stroke may initially appear normal and develop hyperdense changes later. For early ischemia detection, MRI with diffusion-weighted imaging, DWI, is more sensitive. CT or Mr. Angiography helps visualize vascular occlusions, aneurysms, or malformations. For ischemic stroke, the mainstay of treatment is urgent reperfusion. Intravenous thrombolysis using alteplase, TPA, should be administered within 4.5 hours of symptom onset. Mechanical thrombectomy is an option for large vessel occlusion, ideally within 6 to 24 hours. Antiplatelet therapy with aspirin or clopidogrel is given after ruling out hemorrhage. Blood pressure and blood sugar must be carefully controlled, and supportive measures such as oxygen and fluids are provided. In hemorrhagic stroke, the primary treatment is blood pressure control, keeping SBP 140 mmHg to reduce further bleeding. Neurosurgical intervention may be needed for hematoma evacuation or aneurysm clipping. Intracranial pressure is managed using mannitol and head elevation. Addressing the underlying cause, such as repairing an aneurysm, is critical. TIA management focuses on preventing future strokes, using antiplatelet agents, statins, and controlling risk factors like hypertension and diabetes. A non-contrast CT brain scan remains the cornerstone for initial stroke diagnosis. Ischemic stroke requires prompt thrombolysis within 4.5 hours or thrombectomy, whereas hemorrhagic stroke is managed by blood pressure control and surgical intervention. TIA presents transient symptoms and indicates high risk of future stroke.